dimension, but first, the clinical history. The clinical history is very important. Okay. So what is the size of the pancreas? Okay. Because dimensions are very important in sonography. Why is it so? Because you may identify a pathology and then you are the sonographic, normal sonographic pattern that you do. It becomes suspicious that this lesion, this pancreas is enlarged or not. Okay, so always we have ranges for those measurements. And then for the head of the pancreas, it should not be greater than what? 3 millimeters. Okay, centimeters, sorry. 3 centimeters. Okay, the body?
Be greater than 2.5 centimeters.
2.5 centimeters. And then? The tail?
Less than 1.
Yes. Okay, so you scan in the transverse and you've gotten this image. You want to measure anterior posterior. Okay, greater than what? It shouldn't be greater than 3 centimeters. This is the body of the pancreas. You measure anterior posterior and then you expect nothing more than what? 2.5 centimeters. And then for the tail, you also measure and then expect nothing greater than what? 2.5 centimeters. Now, yesterday I also gave you a certain trend that we have congenital abnormalities of the pancreas, right? And then we talk about pancreatic divisum and then annular pancreas. And then we said for annular pancreas, what happens is that the most ventral part of the pancreas encases the duodenum, okay, and then subsequently causes what? Duodenal obstruction, okay, causes what? Obstruction. And then we also have the pancreatic divisum, where we have a shortened main pancreatic duct, okay. So instead of the longest one that we have, it is very short. In that, it's only drain the head of the pancreas without draining the entire pancreas. Okay, that is the pancreatic division. So congenital. We have what? Annular and then division. Okay, for annular, the most ventral parts of the pancreas encases the duodenum and then subsequently is what? Duodenal obstruction. And then for pancreatic division, what also happens is that there is a shortened main pancreatic duct which drains only the head of the pancreas without what? The entire. Okay, that is one. Okay. Now, knowing that we have congenital abnormalities of the pancreas, we also have, when you are scanning, you also always have to check the pancreatic duct. Okay, if the duct is within normal limit or not. If it is within normal limit, at times it becomes very difficult for you to see. Okay, so there's a duct. There's a duct. Okay, it shouldn't be more than 2 what? Millimeters. The pancreatic duct shouldn't be greater than what? 2 millimeters. Okay, we take note of all these things. When the patient comes to you for a scan of the pancreas, yellowing of the eyes, jaundice. Okay, because we know the function of the pancreas, exocrine and endocrine function, for which we looked during the last time. Okay, so we check the duct, very important. Now, at times the duct may become dilated. What may be the cause? Okay, if there is any capillary that is blocking any part of this one, it may cause that in obstruction. And then mostly, if there is a mass, main cause or major cause, if there is a mass on the head of the pancreas like this, okay, what happens is that all those juice that is being produced coming from this side to this side, because we know that it empties into the duodenum. Okay, so this part and then the common bile duct, and then they meet at the what? Ampulla of Vata. We have the sphincter of OD around this point. So when there is contraction and relaxation, it will contraction to open up, and then the muscles will open up for all these juices to what? Enter or pass into the duodenum. Okay, for chemical digestion to take place. So if there is a mass around this side, what happens is that this mass is blocking the flow, okay, of bile from this side. So all those biles that are being produced, that are coming from this side, okay, when they come here, what happens is that they get blocked. Okay, so there's going to be a reversal, and then there's also going to be a reversal. Those is what is causing the duct to become dilated. Okay, so when there's a mass here, what happens is that all the intrahepatic duct may become dilated. Okay, the intrahepatic duct may become dilated. So when a patient comes to you, a jaundice patient, and then there's yellowing of their eye, okay, immediately we just have to scan the liver first to see if there is any intrahepatic dilation. If that is so, what is the cause? What may be the cause? Calcular formation may be a cause, and then you also have mass on the head of the pancreas, okay, and then pancreatic duct obstructions. Those are the cause of what? The intrahepatic duct to be dilated. Okay, so anytime you are scanning the liver and then the intrahepatic duct, they have become dilated, you have, as a sonographer, it's your responsibility to look out for the cause of the what? Dilatation. And then mostly masses on the head of the pancreas cause what? The duct will dilate. Okay, so the pancreatic duct will dilate extensively, and then depending on the severity, and then we also have intrahepatic duct dilatation. Now, we talked that yesterday. We said we have acute inflammation, and then we listed 5 basic signs of inflammation. What are they? There's redness, color, dull, rubor, tumor, fusio laser. Okay, so the patient comes epigastric pain. When the patient comes and they complain about epigastric pain, what are the structures there? What structures are you expecting to what? With linked? Okay, first thing that comes to mind, the pancreas. Okay, the pancreas. Under no circumstance should we go and look out for the uterus around the side, because the uterus or the prostate has no relationship here. Okay, so knowing your anatomy, what organs are we expected to see is very important. Okay, that is why the anatomy is very important, and then we took you through, Joseph took you through very serious. Okay, it's very important. Now, acute inflammation. When there is inflammation, what happens? We have those signs. There's edema. Okay, so if there is edema, there is tissue build up with what? Fluid. So when there is fluid build up within tissues, what happens is that the size of the organ may not be the same as expected. The size of the organ may what? Change. So the normal size, that is 2.5, should be greater because of what? Inflammatory process occurring within the pancreas. So you scan and then you measure anterior posterior, and then you get somewhere around for the body around 3.5. Okay, immediately you scan and then the pancreas becomes so prominent or too prominent, it should tell you that there's something going on within what? Okay, and then you check the patients, you do some maneuvers. Okay, 3.5, and assuming we know that the normal limit for the body, for the head, should not be greater than 3 centimeters, and then you are getting somewhere around 4.5 centimeters. Oh, chairman. Okay, the size has increased beyond the normal limit, and then at times too, you may also scan. There may not be overall increase in size, okay, homogeneously increase in size, but at times there may be focal masses within the pancreas that is causing the whole pancreas to become enlarged. So we have focal pancreatitis. Okay, focal masses, assuming there is a mass within like this, masses, and then the size may not be as expected, and then as we know, the size may increase. So pancreatitis, we also have those as a result only fluid, and then only edema, and then focal pancreatitis. So we have focal masses within the pancreas. Okay, so that is focal pancreatitis for you. So the size of the pancreas may increase. So we have peripancreatic fluid collection, okay, known as atyrocolysis, phlegmon. Okay, we see hypoechoic mass on the anterior side, presenting like a cystic. Okay, so phlegmon. Okay, and then focal pancreatitis, focal hypoechoic masses within. The size may increase. Okay, the patient will come jaundice, yellowing of the eye, and then epigastric pain. Okay, so those are those pathologies that you are supposed to know. And then repeatedly bouts of inflammation. Okay, may cause what? Chronic pancreatitis. Okay, so in the acute phase, we realize that the size has increased. Okay, so in the chronic phase, what are we expected to see on the sonogram? The size may not increase as in the acute phase, but rather the size may decrease in the chronic phase. And then we may have calcifications within the pancreas. Okay, calcifications within the pancreas. So the pancreas, the echo texture may be what? Heterogeneous. So the echogenicity may be what? Hyperechoic. Okay, hyperechoic. The size very small, and then the echo texture may be what? Heterogeneous. With what? In that we have hyperechoic masses within, calcifications within the pancreatic tissue. At times too, we may have what we call a pseudocyst, mostly on the lesser side. So we have a cystic lesion. Okay, a cystic lesion mostly on the tail of the pancreas. Okay, on the lesser side around this part, we have cystic lesions here. So that is called what? Pancreatic pseudocyst. Pseudocyst. Okay, and then as I said, we have pancreatic C. Mostly they are hypoechoic mass. They are what? Hypoechoic mass on the head of the pancreas. Okay, so you are standing and then you realize there's a focal hypoechoic, not hyper. So focal hypoechoic mass on the head of the pancreas. It may signify what? Pancreatic C. Okay, most pancreatic cancers or carcinomas mostly arise on the head of the pancreas. And then we may have dilatation of the common bile duct, the intrahepatic duct, and then the main pancreatic duct will also become more dilated. Okay, we also have islet cell tumors, cystic masses around, and then I think for those ones you should our next meeting then we do those pathologies. Okay, but ideally these are the simple ones that you are supposed to. You compare the echogenicity of the if it is an adult, the echogenicity of the pancreas to that of what? The liver. And then the echogenicity of the pancreas is slightly hyperechoic as compared to the liver parenchyma. Okay, so anytime you are standing, you compare this and then that, and then you realize that the echogenicity in adult is hypoechoic when compared to this one. It should tell you that no, there's something that is going on. Okay, so immediately you look out for the size, the dimension. You measure the head, the body, and then the tail. And then if it is greater than the expected values, ranges that we know, then it should tell you that there's something going on. You check for calcifications within the pancreas. You check for pancreatic ducts if the ducts are dilated or they are within normal limits. Okay, and then you also check on the head of the pancreas, check on the liver. If the ducts have become what? The intrahepatic ducts have become dilated. Okay, and then a whole lot. Check for capillary within the cystic duct. This is a cystic duct. Okay, this is a gallbladder. We have here, yesterday I told you that we have what we call the valve of Hester. Okay, around this side, the cystic duct. The cystic duct being supplied by what? The cystic artery. Okay, sorry, the gallbladder supplied by what? The cystic artery. You have the cystic duct. Okay, cholecystokinin will cause contraction of this one, and then it will spare the bile from this side, and then empty, join the main pancreatic duct, and then empty their content into the duodenum. Okay, so basically this is what